I would be focusing on complex thoracolumbokyphotic deformities and try to make it as simple as possible for a youngster wanting to enter into deformities. I'll start off with certain cases and the questions that one needs to ask. So here is a 35-year-old gentleman. He has been suffering from progressive kyphotic deformity for last 15 years, increasing severe pain from back to the flanks. And for last 1 year, he has observed increasing weakness in his lower limbs. And now for last 3 months, he has been bedridden. His motor power is 1/5 and he has a severe kyphoscoliotic deformity. We investigated him in detail, and this is the MRI picture. On the left lower side, you will appreciate that there appears to be recrudescence of the disease. So once you have this case, the questions that should crop up are, one, whether you need to go conservative or surgical. Conservative mainly whether you would be able to provide with a reasonable result. What would be the prognosis in the short and long term, the level and type of osteotomy, the degree of correction, and then how to tackle the lumbar roots while negotiating the cage. This is an entirely different spectrum. A lady in the 7th decade of life, persistent severe back pain with claudication, failure of conservative treatment in terms of blocks and medications. So here she has loss of lordosis. Now the challenges here are very different. The age, the severity of scoliosis, we are dealing with an osteoporotic spine, and then we have the lower inflection point in the lumbar area. Now, coming on to kyphosis, kyphosis is a normal curvature in the thoracic spine and sacrum, and the Cobb's angle varies between 20 to 40 degrees between T2 and T12. Whereas a kyphotic deformity is excessive forward rounding of the back. The jury is still out regarding the Cobb's angle as far as hyperkyphosis is concerned. And gibbous is a sharp angular deformity. But the overall picture is that it's only recently, over last maybe 2 to 3 decades or even less, that we have started appreciating the importance of correction of these sagittal deformities and their long-term outcome in deformity correction. To provide a very simplistic classification for kyphosis, we have congenital, where you have segmentation formation defects, Schauman's kyphosis. Then you have Angst-Pond, which is reasonably common, infective, pyogenic or tubercular, and tuberculosis, and Pott spine being one of the most commonly seen kyphotic causes of kyphotic deformities in our country, post-traumatic, osteoporosis, tumor, METs, and iatrogenic. So in fact, the topic for today is evaluation of kyphosis. Obviously, we have clinical examination and radiological examination. So we start with a visual evaluation of the patient, look for the coronal and sagittal alignment from patient's occiput to the pelvis, and in fact, lower down, looking to the hips and the knees as well. The next, you evaluate whether there's a hunchback, a rounded curve, or a gibbous. Look for range of motion from cervical to thoracic to lumbar spine. Notice or pinpoint tenderness if you have, if your patient has, and then obviously go on to neurological evaluation to find out the degree of compression and the power and jerks. Thereafter, you examine the patient walking, look for the hip and knee flexion when the patient is walking, and this would sort of indicate the compensation that the patient is trying to do for hyperkyphosis. The as we all know that we are managing kyphosis, and one of the very important factors is falls, and the patient is trying to compensate by flexing to prevent falls. As far as radiological evaluation is concerned, you measure the C7 plumb line. The speakers before me have already discussed about it. The important thing is if the line is anterior to the sacrum, it's positive. And if it is falling behind the sacrum, it would be negative. Basically, it's a line drawn from center of the C7 to the posterior superior corner of S1. The structural evaluation is extremely important for surgical planning. You need to look at the degree of kyphosis, the number of vertebral levels or segments involved, especially when you're looking at a short segment disease. For long segment, obviously, you need to look at the whole structure, right from cervical spine to pelvis. Look for the flexibility, assess the flexibility of the curve, and then finally look for the global sagittal balance. Generally, we get standing X-rays. They have to be a whole spine X-ray with knees in full extension. You get a standing PAAP X-ray views as well as lateral views. For lateral, you need a large film. So that is very important. That is a practical aspect that you need to image the whole spine, include from the cervical region, lower occiput to the pelvis and proximal femur. Thereafter, in my practice, I go in for MRI in all the cases. You can add CT scan as well. Well, we all know that Cobb's angle is the gold standard. It's ideally it should be from T2 to T12, but we all know that on X-ray above T4, it's very difficult to visualize. So we measure from the superior end plate of T4 to inferior end plate of T12. I've already shown that the normal curvature that we think is normal for the young and adult is between 20 to 40 degrees. For elderly, it is on the higher side. And if it is above 50 degrees, we would label it as hyperkyphosis. Coming on to the spinopelvic parameters, we need to look at the pelvic tilt, sacral slope, and pelvic incidence. These are important parameters as far as the pelvic vertebra is concerned. So we consider pelvis as the base vertebra on which the whole spine has been constructed. So one needs to measure this to, these are the various lines. You look at the sacral slope, the pelvic tilt, and you add it to form the pelvic incidence. I would like to draw your attention to this paper. We use electronic or any handheld device to measure these angles. It's pretty fast, and you can even do it in your OPD. Now, coming on to why treat hyperkyphosis? Well, the balance is disrupted. There is increased postural sway. There's loss of energy. And because of all this, there's increased risk of fall. We also know that there is increased risk of vertebral fractures, secondary to increased pressure on the anterior part of the vertebra. There is mechanical restriction if there is severe kyphosis or kyphoscoliosis with dyspnea and decreased vital capacity. It's been well documented that there is higher risk of mortality as well. Obviously, all this adds up to low quality of life, secondary to pain and decreased physical performance. Now, let's get on to the second part of the lecture, which is how to choose the patients for surgery and what are the indications. Well, unremitting pain is first. Thereafter, you have progressive neurological deficit in the patient, progression of deformity, and cosmesis. So, what are these parameters for severe disability, wherein you definitely have to intervene and operate? It was Schwab et al. Who described that if the pelvic tilt is more than 22 degrees, SVA of more than 47 mm, or a mismatch between the pelvic incidence and lumbar lordosis of more than 11 degrees, then these parameters need to be considered as severe disability parameters, and you need to go in for surgery right away. Now, I've just highlighted a few of the common causes of kyphotic deformities and how do you choose. For post-traumatic kyphosis, apart from the TCIS classification, the surgical indication as far as kyphosis is concerned is if there is progressive deterioration in kyphosis or a progressive deterioration in the neurological condition of the patient, if the kyphotic angle is more than 30 degrees or the loss of anterior vertebral height being more than 50 degrees, it's time that you intervene surgically. As far as post-tubercular kyphosis is concerned, we know that it is basically there is paradiscal inflammation, which is the reason or the cause for anterior vertebral column height, which eventually leads to the kyphotic deformity. In pediatric population, there is higher risk of kyphosis, and the reason being cartilaginous vertebral body is prone to destruction along with the continued growth of the unaffected posterior column. So both of these come together, and the incidence of kyphotic deformity is more than 90 degrees in 10% of patients. So that's almost double the percentage as far as in comparison to adults. I'm sorry. Now, in children, the risk factors for exponential increase would be if the patient is younger than 7 years, if there is junctional involvement and thoracolumbar disease, and if there is loss of more than 2 vertebrae. So in this group of patient, the chances of increase or progression of the deformity is higher. So the indications in port spine are progressive neurological deficit, again, progressive spinal deformity, failed conservative treatment, you don't have a diagnosis, or there is severe pain secondary to abscess and instability. As far as Schwab's kyphosis is concerned, the management pearls include curve, which is again progressing or more than 70 degrees, or the patient has severe pain or neurological deficit. Now, coming to the aims of spinal deformity surgery, especially kyphosis, which is very true even for scoli, you have to achieve balance, relieve the pain of the patient, and then prevent recurrence or worsening of deformity. Obviously, all these three need to be taken care of, but not at the expense of any deterioration in neurological status. These are the various types of osteotomies and not part of my lecture. Posterior vertebral column resection is my workhorse. As far as severe deformities is concerned, I would skip this part. I'm sorry. This is the technique, and I'm pretty sure that the authors after me would be covering it. Well, this was the first case. I undertook vertebral column resection along with Pontes to sort of correct the deformity. Especially in severe deformities, you have to be aware that you cannot do too much of neural shortening, and you need to monitor all this through SSCPs and MEPs. After correction, you continue with the anti-tubercular therapy. So this was the pre-op, and this is the post-op which we could achieve. This is the patient almost 6 months after surgery. This was another case wherein there's degens scoli with kyphosis. You need to take the fusion above the dorsal lumbar junction to avoid failures. The coronal correction is important, but we now know that the pain would be resolved by correction of the kyphosis and achieving a lordotic spine. This was the post-op. The third case is a pediatric case of 10-year-old girl, progressively increasing hump in the dorsal lumbar region, paraparesis, the power being 4/5 and Cobb's angle of 60 degrees. This was her MRI. We had to undertake two-level vertebral column resection, all done through the posterior approach. Obviously, with two vertebra resected, we required a long cage, and there were a good number of lumbar roots. So in such a situation, I use the hunch and arlet technique. Again, I would request you to just go through this hunch and arlet technique. It's a very simple technique to insert the cage, and this is the post-op that we achieved. This is another lady, 25-year-old, with dorsal lumbar pain, progressively increasing weakness for last 3 months, not able to walk for a month, with a Cobb's of 55. This was a CT scan with a good amount of anterior compression. This is the MRI with active infection. Again, PVCR at 1 level with an expandable cage and a 4-level fixation. This was an interesting case of a lady in 3rd decade with progressively low back pain with radiation into the posterior aspects of thigh. Neurologically, she was well preserved. She underwent a hysterectomy for this condition, and when her pain was not resolved, she was investigated and then found with this deformity. There was L5 body destruction and angular kyphosis. Again, a posterior approach with an anterior cage placement and L2S2LR screws. So to quickly summarize, for me, I prefer posterior only approach. The most popular approach I undertake apart from PVCR, Pontes. If I am doing a PVCR, then for more rigid curves, I feel Pontes helps. Again, I would like to emphasize that I find in my practice the hunch technique, wherein you place the cage between the roots, to be a useful adjunct for me. And you can achieve good to excellent outcome in pretty difficult deformities. For the youngsters, you need technical expertise, for which you need to join a good deformity surgeon. You need to have the infrastructure, which is a little different from what the neurosurgeons managing spine is like. Again, the whole length x-rays, intra-op neuromonitoring, the classification is different, the management strategies are different, but then you need to get that into your armamentarium. Thank you so much.